Hey everybody, I'm Dr. Deed Harrison. I'm president of Chiropractic BioPhysics Seminars and Technique, and I'm also president of Chiropractic BioPhysics Nonprofit, a spine research foundation. We're coming to you live from the Ideal Spine Health Center and the CBP Doctor Institute here in Eagle, Idaho. What I'm doing is, in these videos, is once a week I go through one of our CBP nonprofit spine research publications. Hopefully you're enjoying these. We'll go through them in a pointed fashion. I still think, even though you watch the video, you should likely read the full text paper, especially if you're a chiropractor, an MD, or a PT out there that's really interested in this work. If you're a patient, this is likely all you need plus a little bit more. But for the doctors out there, please feel free to also supplement these videos with reading the actual full text. What we're going to do this week is we're going to pick up where we left off last week. Our 21st presentation was a non-randomized clinical control trial on extension lumbar traction that I designed, and we first tested and had a first original paper published in 2001. This one, it's not really a CBP-sponsored research project. This is an independent project testing our methods. It's very important to have your work independently evaluated by other persons in different professions or the same profession. To that end, I met some great colleagues from Cairo University in Cairo, Egypt. These are PTs. They've done some fantastic work, and one of the earlier projects that they did was evaluating our lumbar extension traction in a randomized trial. Remember, the one I went through last week, the one I did out of my practice, was a non-randomized trial, and we said, hey, a randomized trial needs to be done on this. So, Professor Ibrahim Mustafa and his wife, Professor Aliyah Diab, what they did is they designed a randomized trial, and they had this published in 2012 in the Journal of Manipulative and Physiological Therapeutics. The title of the paper is Lumbar Lordosis Rehabilitation for Pain and Lumbar Segmental Motion in Chronic Mechanical Low Back Pain, a randomized trial. Now, early on, I had the opportunity to guide them and advise them just a bit on this particular project, how to do lumbar traction and things like that. But this is really on their own. I didn't do much other than, give them a little bit of internet email exchange advice on how to do some traction, sent them some of our works, etc. So this particular project, very important because it's an independent evaluation of something that I personally developed in healthcare. So it's nice to see what the results would be. Did I, artificially, what we call a bias? Did I put that bias into the project that I did in 2001, 2002 unintentionally, because this is my particular design? I don't think I did, but maybe there is a bias in that particular study, being, number one, I did it in my practice, number two, I designed that piece of equipment. So in this current project, what they did is they acquired 80 subjects that fit the inclusion criteria. Here's the inclusion criteria: chronic mechanical low back pain. Okay, you have to have a history of recurrent low back pain, or you have to have a duration of low back pain that's exceeding a 6-month episode. That's a long time, but believe it or not, there's many people out there that have suffered low back pain longer than that. Also, lumbar lordosis less than 35 degrees, using L1 to L5 posterior body lines. Now, if you remember in a previous project that we did, I said 36 degrees is a cut point for chronic back pain in normal subjects. So this is where they got this 35 degrees from. If you're under 36, statistically, you're chronic back pain. I'll show the measurement again coming up. So we have lumbar lordosis less than 35 degrees, chronic mechanical low back pain, no anatomical leg length inequality, no post-surgical subjects, no inflammatory arthritides, things like that, okay? No leg pain, so it's not a true discogenic population with sciatic type symptoms, okay? Now, there's two groups, 40 controls and 40 treatments. The treatment group is going to be the group that gets the lumbar extension traction. Now, both groups are going to be treated 3 times a week for 10 weeks. That's 30 sessions. Okay, 3 times a week for 10 weeks, 30 sessions. That's just under the amount that we do in CBP. We do 36 to 40 visits over 9 to 12 weeks, okay? So we're doing just a little bit less care, approximately 20% less care than the standard CBP trial that's out there. But you'll see that this is pretty close when we look at the results, okay? The treatment subjects, what they get, in addition to the extension traction, the 3-point bending traction, they get infrared, stretching, and some generalized spine exercises. We'll look at what those were. So that's our treatment group. Now the control group is going to get only the infrared, the stretching, and exercise, okay? So the difference is one group gets the extension traction, both groups get IR, stretching, exercise, for the lumbar spine and lumbar region. Now, again, 3 times a week for 10 weeks. The outcomes are going to be upright standing x-ray looking at total lumbar lordosis. Also, segmental flexion and extension in range of motion, displacements or kinematics, looking at relative rotation angles and relative translation distances, okay? So they're also going to look at a back pain rating scale. Okay, back pain rating scale, and we're going to have 3 evaluations. Initial, which is our baseline, following 30 visits, so the next day after the last visit, and then stop care, totally stop care, follow for 3 months. Remember, our previous project, we followed for just over 15 months. Okay, so here's our patient population. If you look at this x-ray here, these are people that have loss of the lumbar curve. They didn't look at true segmental angles in the neutral position, however. That wasn't part of the inclusion criteria. It was only end range end range total lumbar curve, ARA, L1 to L5. So here's the flow chart of looking at subjects that were initially evaluated and then looking at their eligibility, fulfilling the criteria required for the project. So they started with 130 patients were screened. 84 were eligible. 46 were not eligible. Here's why. You know, some of them refused, 15 of the subjects, that happens. And then other ones, they likely had surgery, an inflammatory arthritide, or they had a disc herniation, so you couldn't include them in the project. So you got to realize this is not a random sample of everybody with chronic back pain. This is what we call a convenient sample that fits our inclusion criteria. Okay, so always randomized trials have that type of limitation in there. It's not like you're taking 1,000 people with low back pain and they're all part of the project. You have to go through and weed them out. So you're looking at subgroups of low back pain populations. But this is really the majority of them out there. If you look, 84 of the subjects met the inclusion criteria. So we have 80 subjects actually agreed to participate and signed the informed consent. So we lost another, 4 of the subjects because they didn't want to, sign the evaluation. So we're left with 80 subjects randomly allocated to one of 2 groups. Study group getting the traction with IR, stretching and exercise, and then the compare or control group, 40 subjects that are not getting extension traction, but they're getting IR, stretches, exercises. And then luckily, this is really good, doesn't always happen, but all 40 subjects made it to the 3-month follow-up. This is great. Okay, so baseline demographic comparisons. You always want to make sure that your groups are truly matched. Now, you never know, but the theory with, randomized trials is it should all even out, right? So here's what we have. Age, 46 years of age, 46, so the groups are matched. They're matched for height in centimeters. They're matched for weight in kilograms. Just a little bit heavier in the control group, but not much, okay? Male and female ratio, evenly distributed. Employment status, part-time versus full-time versus unemployed. You can see there's a few more unemployed in the control group. Do they smoke, etc.? What is their ethnicity? Now, these are subjects in Cairo, Egypt, so most of these are going to be non-white subjects, of course, right? Non-Caucasians. Previous back surgeries, we can't have any in there, but look, almost 3/4 of the population in both groups are taking medications, right? And that's pretty standard out there. And then are you using physical therapy or using other things like acupuncture, nutritional supplements, etc.? So the groups are really closely matched. Now, here's the traction they did. Our traction that we looked at yesterday was the one on your reading right. My younger sister is the volunteer. You can see I advised them, I said, look, we have to tie down the rib cage. This stops the thoracic curve from extending, so we don't want to see a flattening of the thoracic kyphosis. That's something we've learned. We tie down the tops of the femur head area, or just at the bottom of the inferior aspect of the pelvis, and then we load in the distal lumbar spine at the appropriate angle. They developed a computerized method of doing this where it would load and then slowly ramp down the load to a certain amount and then ramp back up. It's a type of oscillatory load, but it's still maintaining at least some kind of load. So it ramps up and then it ramps back down, but there's always a certain amount of load being applied to the spine. Okay, so they're doing this traction 3 times a week, up to 10 to 20 minutes in the traction. Now, what's not shown, I don't have a photograph of what they did. Stretching exercises were performed for their erector spinae muscles and hamstring muscles. Now you can get what the leg stretches would be, right? Because people think, oh, you know what, you've got loss of the lumbar lordosis because your hamstrings need to be stretched, right? You know what, we're going to find out that's absolutely nonsense. Doesn't work. You can stretch your leg muscles till the cows come home, and it ain't changing your lumbar curve out there. This is something that chiropractors and PTs and MDs and exercise science people need to kind of get a hold of. They're telling patients inappropriate things. Now, I know that because I've read this RCT and we've seen other things in the past, but you're going to find out this type of work does not change the lumbar curve. You don't have a loss of the curve because your leg muscles are tight. It's complete nonsense, right? To be direct with you. So we're going to do this. Each movement's going to be held for 30 seconds. And then each of the exercises are going to be performed 3 times a week as well. All these things are done in office, in session. Okay, so let's look at the before and after pain scales. Okay, so the study group is in the red bar, the control group is in the gray bar. Now these people are chronic, moderate low back pain. They are matched. We've got a 6 and just above a 5.5 on a back pain rating scale. So these are chronic, moderate pain subjects. Now look, after 30 sessions, the traction group drops down to just above 2. Just above 2. That's about a 70% improvement in chronic pain. Okay, real close to 70%. Look at the compare group or the control group. Now they improve, but they do not improve as much. They're only about 40 to 45% improved if you look. There is a statistically significant difference between these two groups. So we know that something is happening from the traction. However, both groups feel better. Why? Because they're doing stretches, they're doing exercise, they're doing IR. However, the traction group that gets improvement in the lumbar curve, we'll see, they get a little bit better. Now, here's the important part. Initially, almost all interventions out there, let me repeat that, almost all interventions out there will make people feel better initially. So you take a drug, you feel better while you're on the drug, right? That's what they do. Doesn't mean they're fixing anything. Your pain receptors, they're blocked. Now you don't feel this. The infrared, the stretching, things like that, that will also improve back pain intensity, at least while you're doing it. The important thing is what happens when you stop. Okay? When I stop doing these things for a period of time, what's going to happen? Does the pain come back? If it does, it didn't do anything for you permanently. If the pain doesn't come back, then you can go, well, happy day, something good happened here. So 3-month follow-up, no care. Look what happens. Study group gets a little bit better. Man, now they're more like 80% improved on this back pain rating scale. Look what happens to the control group. Man, the control group shoots back up near pre-study values, meaning this didn't do much for them at 3 months. They're still suffering with chronic back pain. You know, if you're a person out there suffering from chronic back pain, it's not rocket science. You go, which group would you rather be in? You'd pick the study group that got traction, you know, because at 3 months, now look what's happening to the group that didn't get the traction. You're ramping back up to where you started. Not a fun thing. Here's why. If you look at the two groups, when we start to look at their alignment, there's something very important happening here. The control group that did not get traction, their alignment stays the same. Let's look. This gray bar here, this is the study group. Look, they're at about 15 degrees. What's normal for the lumbar curve? Closer to 40 degrees. We've got a huge loss of the lumbar curve here, right? You know, what is the loss of the lumbar curve here? Well, you know what? It's well more than 50%. It's well more than 50%. You're looking at like a 38% loss of the lumbar curve, okay? Look at the control group. After stretching your hamstrings and your back muscles in infrared, nothing happened. Your lumbar curve looks the same. It doesn't change it. We've known this for decades in healthcare, but yet you go to these certain specialists and they tell you, oh, just do these stretches, just do this exercise, it changes your lumbar curve. Well, you know what? They never take a follow-up x-ray. They only look at you externally with their eyes, and you can't tell what the spine looks like compared to an x-ray. Here's what we found. No change by doing that. 3 months later, guess what? Still no change. Doesn't look any better. Why do you think they're starting to hurt again? Their lumbar curve is so far reduced, it's 15 degrees instead of 40 degrees. Mechanically, it's compromising the tissue and it's causing back pain. Now you look at the study group. Quite a different scenario here. Under 15 degrees, bang. Now they're up above 20 degrees. There's a statistically significant improvement in the lumbar curve. How much? Excuse me as I get a little excited here. It's at least 7 to 8 degrees improved. Now, if you remember the study from last week, I went through and I showed you in 36 sessions, we got 11 degrees. Okay, this is really close. You take 20% off 11 degrees and you're, 2 to 3 degrees. Subtract that 2 to 3 degrees, you're 8 to 9 degrees. Correction, if I only do 30 visits in the population that I did, these guys got 7 to 8. Do you see how close they are? When I looked at this, I was like, woohoo! I'm going to get a little excited here because it made me feel like, wow, I didn't, taint my data. I did everything right, non-randomized trial, and the results were confirmed, 10 years later in a randomized trial. Sorry if that comes out a little loud on the microphone, but you got to realize this is exciting for me to see a decade later somebody reevaluates my work and they find nearly identically the exact same thing within the number of treatment sessions, right? Looking at, similar ideas, but a different study design that may be more robust in a randomized trial. Okay, so this was really cool. Then you look at 3 months later, look what happens. They lose just a small percent of the lumbar curve correction, but it's really not that big of a deal. It's barely a degree that they've lost over time. So the traction group is improved. Now, it's not rocket science here either. Look, we stopped care. These subjects still have a loss of their lumbar curve. This is likely why, go back to their pain, they still have back pain. Why? Well, because their lumbar curve is not normal. We're doing a randomized trial here, and as part of the randomized trial, you got to stop care after 30 sessions. The patients don't get the option of going another program of care. Now, in the real clinical world, we would say, hey, let's keep going. Patient A, you got a great change initially in your lumbar curve, but it's still not normal. Let's keep going, right? But that's not what was done here. This is why it's informed consent and part of an institutional review board approved project, right? Because you're experimenting on a population. But notice there's strong differences in the lumbar curve between the two groups. Perhaps one of the most important parts of this, from the clinician's point of view, is there's statistically significant differences in the way the spine moves between the two groups. Now, as a chiropractor, we're always using spinal manipulative therapy, and we're trained that that's what improves joint motion. However, in biomechanics and mechanical engineering, we find out that static alignment, the alignment in the neutral position of a structure, will influence dramatically its dynamic characteristics, its kinematics, its movement. Statics and dynamics are totally related. Okay, so what does this mean? Well, in this project, we did not do, I say we, I'm including myself in it because obviously I wanted to be, but you guys get the idea. I'm not part of this project. But they did not do spinal manipulation. So we've removed that from the equation. Yet, what we find out when we look at movement characteristics in the spine, the group that got traction got improvement in their segmental translations and segmental rotations, statistically more than the group that got stretches, IR, and exercises. Why? Well, because the group that got traction improved the lumbar curve. That changes the way things move in the spine. So look, study group. Study group is always the first one on top at L1, L2, and then the compare group, control group at L1, L2 down here. So if I look at, let's go to L2, L3. So if I look at L2, L3 in the study group, look at the yellow triangle, you can see there's dramatic differences in the amount of translation movement that is happening here. This one is quite reduced initially. It improves, and then it stays improved at long-term follow-up. Let's go down to the control group at L2, L3. That's that square here, the orange square. Look at the difference. You know what? It appears that they lost a little bit of their movement, right? If you follow each level, you'll see most of the time, each level has a statistically significant difference in the treatment group that got traction compared to the control group that didn't. Now, this graph is looking at segmental translations or linear straight line movements in the sagittal plane. This one looks at segmental rotations. How much can you flex and extend in the sagittal plane, like bending forward and touching your toes or bending backwards? You'll notice the same thing. The treatment group gets dramatic changes that are statistically significantly different, whereas the control group does not get the statistically significant differences found in the treatment group. In other words, static dictates dynamics. If your lumbar curve doesn't change, your movement patterns don't change. If your lumbar curve does change towards normal, then your lumbar movement patterns start to change towards normal. Now, this is a great project. This, for the first time, shows that extension traction statistically is what changed the lumbar curve, and it changed the type of movement that happened in there. Now, if you remember our previous project, because we did spinal manipulation in our treatment group, we couldn't claim that the pain improvements and the lumbar curve improvements were due to the traction. That's why an RCT was needed. The RCT, we used traction as the variable. So it was the variable that was removed in the control group and added to the treatment group. It was the thing that caused the lumbar curve to increase. Okay, we've seen that it compares very closely with the previous non-randomized trial 10 years earlier, both from the lumbar curve perspective and from the pain improvement perspective. This is a very important finding. So we can now look at this and go, there's no way it was the spinal manipulative therapy that improved the lumbar curve. Now, it may have improved some of the pain, but as we see in this study, some of the pain was also improved by the actual traction. And we see it's maintained at long-term follow-up in this randomized trial. You can't understand how excited I was when this came out in 2012. I only had a few people that understood and I could share that with, but hopefully you guys have seen kind of my enthusiasm and excitement for this. For a long time, researchers at different conferences would say, well, Dr. Harrison, you haven't really independently evaluated this work, so we really don't know. We really can't trust your data because it was your data. And you know what? That's a fair criticism. Honestly, you take that to heart and you go, yeah, I need somebody to reevaluate this in a randomized trial format where I'm kind of removed or completely removed from the process. And when this came out, I was like, yeah, it came out. I looked at it, I was ethical in my first project, and then now the whole world knew that I was ethical in my early project because these results came out and found the same thing. So here's the summary. This study provides objective evidence that biomechanical dysfunction in terms of abnormal lumbar curvature in the sagittal plane, and not just bad anatomy like a disc herniation, etc., influences pain and sagittal plane movement patterns. Okay? In other words, when you lose your lumbar curve, you're going to have pain and you're going to have loss of the range of motion. How do we know that? Well, in the group that got restoration of the lumbar curve by 7 or 8 degrees, they're the ones that got the best pain improvement and the best movement pattern improvement, and it was maintained at 3-month follow-up with no care. The study group, in contrast, the study group, their changes are consistent with those of me. Right? What I did in 2002, who conducted a non-randomized trial to evaluate the effects of this type of traction. So that they actually put that in the summary, which, they didn't need to do that, but that was quite nice of them to put that in there. Made me feel real good. So we see that there's strong differences in the control group versus the study group, and those results are consistent with my previous paper in 2002. Again, this is the type of traction that we're looking at. 3-point bending, supine on your back, extension traction to improve the lumbar curve. Now, what we're going to look at next week is 2 follow-up randomized trials, or in the next 2 weeks, on this very same project, or this very same type of study. We do have to be careful as clinicians when we have a patient that has stenosis and true disc herniation. We have to go slower, and we have to realize maybe the results are not going to be as profound initially, but we're going to look at that in the next couple projects that were done by these 2 brilliant researchers out of Cairo University. So if Professor Ibrahim and Professor Aliyah are listening to this, my hat goes off to you. Thank you so much. It's an honor to have you guys look at this work. And it was exciting for me to see that. So I simply, can't thank you guys enough to have an independent party like Cairo University look at this work and then have it published in one of the top chiropractic journals out there, the JMPT. So hopefully you've enjoyed this presentation. And if you're a patient out there, let's consider going to a CBP trained chiropractor. Listen to the message at the end. If you're a chiropractor, a PT, and MD, you know what? If you like this research, please consider supporting our research. Donate to us. You can help the cause. In the end, this benefits all of the patients out there with chronic back pain. No one discipline has the answer. We all have to collaborate and work together. And hopefully you'll find value in this type of presentation, and you'll think about supporting CBP nonprofit. Thank you very much for your time and attention. Talk to you next week. Like this information, if you're a patient, you need to go to a chiropractic biophysics trained chiropractor. You can find us all over the United States, Canada, and international locations. Go to www.cbppatient.com and look up CBP providers in your area. It's an easy-to-use, user-friendly site. Search for, at first, a general or advanced trained CBP chiropractor. If you can't find one of those, then find somebody that's at least on the directory and has taken our courses and that does the work, okay? So let's go to a CBP trained chiropractor, www.cbppatient.com. If you're a chiropractor and you're interested in this, either learning more about it or maybe it's brand new to you and this particular video research project intrigues you, come to our website for doctors. Go to idealspine.com. We've got a lot of things there for you. We've got training, we've got conferences, we've got products. Love to have you on board and become one of the CBP doctor family providers, right? We need your help. There's patients out there that need you, and if you don't get trained in this work, then you're not going to be able to provide them the type of service that we think you should be providing them from a corrective care point of view. Also, lastly, anybody out there, we also need your help to continue to do research investigations like this, right? These are time and dollar consuming projects. If you will, go to our website directly and sponsor and support Chiropractic BioPhysics nonprofit. Make a donation of any amount to us. Also, you can do it indirectly on Amazon Smile. Just select Chiropractic BioPhysics as your nonprofit foundation, and when you purchase through Amazon Smile and Amazon, CBP nonprofit will get 0.5% of all your purchases, which is a big deal. It adds up.